Hello.
Hello.
Hi, should we begin?
Yeah,
Or you
Doctor.
want to wait for a while? No, right?
No, we can start now.
All right. Looks
Okay.
good. I think we have.
Good evening, everyone. Respected Dr. Agash Takwani, sir. Respected members of IADP. A very warm welcome to all of you. We are delighted to welcome you back to yet another episode of Learn from our Master series organized by IADP. Crossing 75 webinars has truly been an amazing journey, and on behalf of the entire team of IIDP, I sincerely thank all the doctors who continuously support us by attending our webinars and following us on platforms like Instagram, Facebook, and YouTube. Your encouragement and the positive feedback keep us motivated and humbled. For those who are attending an IATP webinar for the first time, a brief introduction. We are the International Association for Dental Practice Excellence, a professional dental platform built on the belief that quality education ensures predictable clinical outcomes, irrespective of dentist specialty or experience. Dentistry is ever evolving and complex, and continuously learning is essential. With the vision, IADP conducts webinars, workshops, and academic programs aimed at enhancing clinical skills and guiding dentists throughout their professional journey. Without further delay, let us begin today's session of the Learn from Master series. And today's topic of discussion is temporization in fixed partial dentures. And it will be delivered by Dr. Akash Takwani, sir. Allow me to briefly introduce today's esteemed speaker. Dr. Akash Takwani is a gold medalist in prosthodontics, trained under Professor Dr. N. Sridhar Shetty. He completed his master's degree in 2014 and later co-founded Keramicos, a dental laboratory renowned for precision Emax restorations. In 2017, he established Janmaga Academy of Dental Excellence and has since been actively involved in delivering lectures and workshops across Gujarat and India. He is a leader in implants, restorations, and dental photography and has received several prestigious honors, including Best Secretary in 2017 and Best President National Level 2023. With over 25,000 followers on Instagram, he continues to inspire clinicians with his clinical expertise and educational content. Without wasting much time, I now request Dr. Akash Takwani sir to kindly take over today's session. Sir, please.
Thank you so much, Dr. Juna, for a lovely intro, which I only provided to you. Well, I'm really glad that we are roughly 90 participants, and they all preferred to choose to listen to me over any weekend plans. So I will definitely not waste any more time, and we can straight away jump to the topic, which is temporization in FPD. Let me just start sharing the screen. So just let me know if my screen is visible and
Yes,
as well as if I'm audible enough.
yes, doctor.
All right. So we will be talking about temporization in FPDs. Um, as per my knowledge is concerned, we have been running away from from temporization, and I believe that this is mainly because we're not really sure whether we can do it in every clinical situation, whether we can do it or not, or whether it's going to be expensive for us. Well, none of it holds true. And I believe by the end of this session, we all will be on the same page. So I will briefly introduce myself. I am a fellow member of Indian Prosthodontic Society and Indian Society of Oral Implantology. We own two branches of a dental clinic, and we have our own dental laboratory where we make our own Emax restorations. Um, so it's since the start that I have been wanting to give work to the patients, which is first hand made. I love to fabricate my own prostheses. So it all started with good temporaries, and then I thought if I can make good temporaries, why not make good permanent restoration? So I have been a guest lecturer at various events across the country as well as state, and I have my chief interests in smile designing, dental implants, dental photography, and documentation. So I just have one question. Is there a lot of music audible at the back? Because I don't know. There's recently some road show that is happening, and they've started playing loud music. So, are my earbuds able to do the justice? And is is my audio clear, or is there disturbance? If I can get a quick response from somebody,
Yes, sir.
am I audible enough, or is there a lot of disturbance?
No, it's
It's
audible, doctor.
It's manageable, right?
Yeah, yeah.
All right. All right. So we will be talking about temporization under the following headings, which is introduction, why temporize, materials and their properties, fabrication techniques, provisional luting cements, and removal techniques. So to start with, what is a temporary? Now, well, this trust me, this is the only theoretical slide of the whole presentation. जिसमें हम definition पढ़ेंगे because this is important. It's a fixed or removable dental prosthesis or a maxillofacial prosthesis designed to enhance aesthetics, stabilization, and or function for a limited period of time, after which it is to be replaced by a definitive dental or maxillofacial prosthesis. This is very important because this is meant for a definitive purpose. You are not supposed to use it forever. Many a times it happens that a good temporary might look so stunningly good that you or the patient might be like, Chalega, we will use it forever. No, don't do it. It's not meant for that. It is meant for a very specific period of time. So these are two interchangeable terms, interim process and temporary. Interim means it is established for time being, say 3 to 6 months in some cases, whereas temporary connotes laxity. It's a casual fabrication and it can be used for up to a few days, say 4 to 5 days, up to 1 month. Okay, very important. So before we learn how to temporize, it is important for us to know why to temporize. And by this, I should be able to make sense that why I personally choose to temporize almost all my cases. When it's a vital tooth, it's very easy for us to understand. It provides pulp protection. Okay. It forms a barrier. It preserves the vitality. What happens is, say, maybe for a day or two, you leave the prepared tooth without temporizing, it's okay. For more days, the patient develops sensitivity. Repeated sensitivity leads to pulpitis, and this reversible pulpitis can go to irreversible pulpitis, leading to pulp non vitality. And sometimes you might be like, initially, it was fine, but now there is constant pain. And that is because it was not temporized. And ultimately, you have to end up doing root canal. Okay. So, insulation and sensitivity, caries prevention. See what happens sometimes it's an anterior case. Okay. Say you have to remove lower four anteriors. So there is a treatment provision which you can offer to the patient that on the same day you prepare the canine on both the sides, remove all the four anterior teeth, and give temporary on the same day. Now, say this is going to stay for almost 1.5 months till the socket is healed. And in this case, you want a temporary which does not let the prepared teeth get affected by Streptococcus mutans. So it helps in caries prevention. So it basically forms a bacterial barrier. It seals the margin. And of course, if the tooth has a temporary, if the prepared tooth has temporary on it, it is readily cleansable. Coming to the patient comfort and function, obviously, patient comfort is of utmost importance because you do not want to leave the patient without a temporary with really sensitive teeth. Even if it's anterior teeth, the aesthetic is not just only concern, even phonetics. There are many words which require a lot of presence of natural teeth because you do not want the patient to slur or to lisp while he is talking. And of course, psychological benefit. Say, if I leave you without a tooth in your anterior region, I'm sure you're not going to step out of my clinic. So it is very, very important for us to temporize when it comes to patient comfort and function. Assessing preparation adequacy. Now, say you did mock-up. Now, mock-up is something which, if you don't know what is a mock-up, I will not be able to help you in this particular seminar because that itself is a 45-minute seminar altogether. Basically, it's something that you do on a cast using a mock-up wax so that you can give temporary or you can use that as a model to either teach the patient or to basically guide the lab guy how to make final prosthesis. So, say you have a mock-up जिसमें आपने anterior teeth say 3 to 3 you have asked the lab guy to do mock-up for you because the patient wants smile designing. Now, how much to reduce will depend on the mock-up. So you can always do good mock-up and then give temporary and then decide whether the preparation that you have done is adequate or you need to do more. Okay. Well, undercut detection. Many a times ऐसा होगा कि you've sent the work to the lab and then you get a call from the lab guy that, sir, there are undercuts, you'll have to repeat the preparation. If you made a temporary, you will see during the process how we remove the temporary. Now, if there is an undercut, the temporary will just not come out, which automatically means that there is an undercut. So the things that generally your lab guy tells you, you can do it beforehand in your own setup. And coming to margin evaluation. Uh, of course, with a good temporary, you can evaluate if the margin has been given nicely or not. Okay. So, Dr. Juna, do we have a provision of people who, if they have any doubts, they can ask in the middle, or they are supposed to note it down and then ask at the end? How do we? How is it? Do we have question answer round? All right. If there's anything, you can just raise your hand or put in the comment section, and I'll see if I can answer. All right. Coming to the lab communication. Um, just a second. I'll just take a small break to check if yes. Okay. Audible. And we have. All right. So should we just continue? Okay. Coming to the lab communication. Uh, say a patient comes to you and wants um the incisal edges of his anterior teeth to be increased by 1 or 2 mm. Say the patient says that मुझे दांत छोटे लग रहे, I want my teeth to be a little longer. Okay. So you do mock-up, give temporary. Now, when you give a temporary, you ask the patient, do you like this length? Because in the mock-up only, what you did was that you increase the length. So now the temporary that you will give will be little longer than the natural teeth. Now you ask the patient, you are happy? The patient says, yes, I'm fine. All you need to do is just take a scale, put it next to the prepared tooth, जहाँ पे you take the measurement from the gingival margin to the incisal edge. Now, this measurement directly send this picture to the lab guy and tell them कि मुझे मेरे permanent restoration 11 mm long चाहिए. So the lab guy exactly knows that the length of the veneer or the crown is to be kept 11 mm. So basically, we are talking maths. We are not just explaining the lab guy in a very vague fashion. You are telling him or her in a very standardized approach. Okay. Parallelism evaluation, this is very important. Say you're doing a bridge and you are not sure whether the abutments that you have prepared are parallel or not. You make a temporary bridge. If it comes out easily without getting stuck anywhere, means the abutments are parallel. If it doesn't come out, means there is some problem with the parallelism. Okay. So basically you can check the path of insertion by giving a temporary bridge. It's as simple as that to understand. Immediate tooth replacement. Say the patient comes to you with a mobile upper central incisor, and you are like, okay, you'll have to remove it. And then you tell the patient that I'll give you an implant, and on the same day I'll give you temporary. Patient like, bingo, let's go for it. Kitna kharcha aayega? And then you tell the patient 40,000, 50,000, whatever. And patient is like, my God, I don't have that much money. I don't have that much budget. So I'm like, okay, we'll remove the tooth and we will let the socket heal. You come back after 1.5 months and I'll give you a temporary. You think the patient is going to go out of your clinic without a tooth? No. So in that case, you can do immediate tooth replacement by giving a bridge without using an implant. And I have a case by which you will be able to see. So, of course, in the anterior case, it promotes aesthetics. If it's a posterior tooth, it provides function. And also, if it's an immediate extraction, you give a nice pontic, ovate pontic, it will actually give you a nice emergence profile. You will see a case wherein I have given temporary to sculpt the emergence profile. I hope you're all with me because I'm not sure if I'm able to get any feedback. कोई भी अपने आप को unmute करके you can just say yes so that I'll know because I don't think so I can shift from the
Yes, sir. Yes,
PPT.
sir.
Okay,
Yes.
amazing,
Yes,
amazing,
sir.
amazing. That's amazing. Oh, I hear some familiar voices. Nice. Okay, going ahead with preventing abutment migration. I'm sure you must have seen that you prepared the tooth, you have done the scans, you sent it to the lab, or you made the impression, you send it to the lab. The lab guy is very fast and he sends you the work in just 24 hours or say 48 hours, and you try to fit it, and there are a lot of high points. And you are like, seriously? It's just 24 hours. Do you know how fast can a tooth migration happen? In less than 3 hours. 2 to 3 hours is more than enough for any tooth migration to happen. So you think anything justifies not giving a temporary? हाँ, फिर क्राउन आने के बाद हम उसको अच्छे से घिस के पॉलिश करके मेटल एक्सपोज करके दे सकते हैं. सो ऑल दोस गिमिक्स कैन बी डन, बट वो सब नहीं करना है, इसलिए आप यहाँ पे सैटरडे रात को मेरे साथ बैठे हुए एंड यू आर लिसनिंग टू दिस. So you do not want the abutment to migrate either occlusally or gingivally or mesially, distally, buccally, labially. Okay, you want to prevent the drift and you also want to prevent it to extrude. Okay, enhancing aesthetics. Now, how? This is a step forward to just not replacing a tooth merely, but to also check. Say the patient comes to you and patient says that, sir, मुझे मेरे दांत बहुत अंदर लग रहे. The patient feels the teeth are retruded. Okay, so they will say it in a layman term, but we have to understand it's the problem is with the retrusion. So you want to do mock-up, you want to do tooth preparation, you give temporary, and with the temporary, you check if there is adequate lip support. You ask the patient, how do you feel now? The patient says, it's fine, amazing. So now what you do is you remove the temporary, you take a wax gauge or a metal gauge, it's an instrument. I'm not sure if I have a slide showing that instrument, but if we have a group or something, I'll just share the image right away. It's a very important tool. उससे आप thickness of the crown measure कर सकते हो. You put it anywhere. and you check. So say the thickness is showing 1.5 millimeters. You just tell the lab guy, please make the processes 1.5 millimeters of thickness, and you will get exactly what the patient approved. So again, we are talking maths. We are conveying maths. We are not just saying thoda mota karna. There's nothing like thoda mota, thoda patla. Okay. Of course, with this, you can do the contour assessment, meaning you do not want the gingiva to stay understimulated or overstimulated. Okay. Incisal edge position. How? Say I want to say the word the. Now I am able to say the because my upper and lower teeth are perfectly placed in harmony that I am able to say the and not, okay, I'm not lisping or I'm not going berserk when I say the. But it's not possible. अगर मैंने अपने incisal edges, even if I shift them 1 mm anterior or posterior, I will not be able to say the or sir. So sir is basically, I'm sure you all know Silverman's closest speaking space. It is just that sound which is made when the teeth just come in contact with each other and move apart. So incisal edge position is very important. Now, you do not want these things to be checked in your permanent restoration because it's going to take a lot of time. You just do all the changes that you need in the temporary and just send a scan of the temporary to the lab guy or just make an impression after the temporary. Ask the lab guy exactly ऐसा process बना के दो. खत्म. Okay. And emergence profile that we will talk in the case that I show. Promotes periodontal health. Of course, if it's a prepared tooth and you leave it as it is, the gingiva is not going to know where it is supposed to rest. So if you give a temporary, gingiva is at peace. Okay. Because it has polished surfaces, it has a good margin placement. Patient education tool and compliance assessment. How? Say you gave a temporary and you have asked the patient कि हम smile designing करेंगे. You committed for 20 years. It's a big case, 3-4 lakhs. Now you do not want the patient to come back in 2 years with half of the teeth mobile. Basically, you want to check whether the patient is keeping the teeth clean or not. Do you really want to do that by giving him a Mercedes, whether he can drive or not? Try, ask him, like give him a Honda or a Hyundai and see how he as a driver and then give him a Mercedes, okay, or a BMW. So you ask you check the patient's compliance with the temporary. If the patient is not keeping the temporaries clean, tell them that if you do the same with your permanent teeth, they're not gonna stay. So it's just one more reinforcement tool. Periodontal dressing, very, very important. Say you've done gingivectomy or a crown lengthening procedure and you've done the preparation on the same day. And if you don't temporize, the gingiva is gonna fall. And if it falls, you do not know where the margin is. You cannot do the final scan or final impression after the stipulated healing period. So when the gingiva is healing after a crown lengthening procedure, you make sure you temporize the tooth. In full mouth rehabilitation, you can always evaluate the occlusal scheme, whether the patient is happy with canine guided occlusion or whether you want to give group function. So I believe uh, we have more than enough reasons. I can go on. You can even check whether the vertical dimension that you have chosen for a full mouth patient is fine or not. Say you chose to raise the bite by 1 mm, and then you are seeing still you don't have enough space to accommodate teeth. You can choose, you can change the vertical dimension even after temporizing. So it basically helps you choosing the vertical dimension. And coming to the very important question, I am a Gujarati, so definitely this is one thing that I'm gonna tell you. You know how much does it cost? Even if you choose the best material and choose one of the best techniques, it's not gonna cost you more than 120 rupees per crown. Now, so don't tell me that because it's costly, you do not want to do it. Because it's time consuming, you do not want to do it. It costs you 120 rupees. Either you bear the cost or you charge 300, 400, 500, how much ever you want from the patient, but don't let cost come in something which is very important. So, was I successful enough to sell it to you? If I have sold you the temporary, let me show you how to make it. Okay? A very, very brief slide on classification. Someone's mic is on, and I hear a cute kid talking. Must be very cute, but अभी हम थोड़ा फोकस करेंगे. So I request कि आप अपने आप को म्यूट कर दीजिए. Hmm. Now, based on method of fabrication, we have preformed and custom made. Based on the material used, we have resin and metals. Based on the duration, we have short term, long term. But what we are going to talk or discuss is based on the technique of fabrication, which is direct and indirect. Okay? We'll just remember these two things because clinically only these two things are applicable. Now, in direct technique, I will be very direct. There is this very nice material by GC called Revotech LC. I do not have it in my practice. I don't do it, but I've seen many of my friends who are practitioners and they love this material, and I used it. It was good, and it's a very casual way of fabricating. So this is what you do. So it's available in this stick form. Do you see a white a stick which is A2, A3 shade? That's how it is available. So say this is a prepared tooth. You apply a coat of petroleum jelly so that the temporary is able to seep out. Now you take little bit of the material from that case, you mold it into a basic shape, you put it on the prepared tooth directly, then use any instrument and sculpt it. Once you have sculpted it, cure it. Once you have cured it, directly usko remove karo and you check a very casual kind of a crown is already been formed. Now with your trimming, finishing, polishing skills, you can make this into a nice temporary and then just stick it. Simple. With what to stick, I will be talking after we have discussed the indirect technique. Okay, so that was direct technique. We will move ahead with the indirect technique using BIS GMA. Basically, it's a BIS acrylic. This is the most commonly used and the most effective way of temporizing in my point of view. And I will be talking why. Okay, so for this, you need a cast or patient's patient's cast, and if necessary, you also need a mock-up on the cast to be done. Whether you do it yourself or you ask your lab guy to do. Right? Now, this is the material. You get it by the company called 3M. It's called ProTemp 4 by 3M. The ProTemp came with ProTemp 1, 2, 3, and 4 was the last invention. And that happened in 2012, 11, 12 or something. And since then, since 14 good years, this material has stayed adhikam in the field of dentistry. I have been using it for past 14, 13, 14 years. And I'm absolutely mesmerized by this. But then there are many other material like Luxatemp, then even GC has it. So you can use anything which has this GMA, okay? This acrylic. So I will be discussing the indirect technique with this case. Can someone just unmute once and say you are with me or perfect or whatever you want to say in your own language so that I know we are on the same page?
Yes.
Yes,
Yes,
doctor.
sir.
Yes,
Yes,
sir.
doctor. Very
Perfect. Awesome. Awesome. Thank you. Thank you. So this is a patient who came with two central incisor where we all can see they are broken because of some accident which he came across a few years ago. And we see one discolored tooth, which is 1-1. Okay. Means it was non-vital. So we did root canal. And for the 2-1, we chose to give a veneer. Okay. And for 1-1, now for 1-1, we gave a crown. Now, label aspect, you see both of them, you see, okay, thoda sa labely proclined hai. and they are short. But when you see from the occlusal aspect, the tooth 1 1 is very much labially proclined. Okay. So in this case, you want to do mock-up. So basically on this cast, I did mock-up, and then when you see the mock-up done from the labial aspect, I have corrected the length of the edge, incisal edge, and from the occlusal aspect, if you see, I have corrected the labio-palatal orientation. Okay. Now we make a putty index of this. This is the putty index. Now we take this material, which is called, so I use ProTem. It is available in 10:1 cartridge. So the gun is different from the one that you use for your uh, polygonal siloxane or the A-silicon. That gun is 1:1. This is 10:1. You need different gun. Cartridge इसका आता है and उसके साथ उसके tips भी आते हैं. If you do not have the tips, you can buy it from your vendor. Ask them to give you 10:1 tips. Okay, so please remember 10:1 gun as well as the tip. Now just dispense the material. Now one thing that you need to ensure is when you are pushing the material inside the putty index, you ensure that the tip is touching the base. Matlab right, it should be near the edge. You make the material flow, and in a circular fashion you come up while filling the whole space. Okay, are you with me? Got it? धीरे से नीचे डालना है edge के तरफ. You have to fill it and keep coming up so that there are no voids. Because even if there's a small void, you as a practitioner are not going to like, and that one void will keep coming in your mind for 3 days. So you do not want any void. Okay. And simply place the putty index back on the prepared teeth. You should know how to do the tooth preparation. Once the preparation is done, पट्टी इंडेक्स में प्रोटेम डाल के उसको वापस प्लेस कर दो. Let it set for a minute or two. So you can always dispense some material on the side to check whether it is set or not. Once it is set, remove the putty index. The temporary might stay on the prepared teeth or it might come along with the putty index. Both are okay. Then tease it out with a probe, and once it is out, you will use these instruments. You can click a picture of this. These are the instruments that I have. Okay. And these are, इसमें से आपको 2-3 इंस्ट्रूमेंट ही लगेगा to finish and polish this crown. Okay. So now you see there's a lot of excess. So first, with any aerotor burr, TR13 or TR13C, you can do gross reduction. Then I'm using this green stone. Okay. It is basically a finishing stone to basically uh, give the final shape of the prosthesis. Now I'm using this disc in the interdental region so that when I place these crowns back, there is no material touching the papilla. Now, this is very, very important. You do not want anything to touch the papilla because papilla is very sensitive to these materials. जैसे ही कुछ material touch करेगा, the papilla is going to recede or stay inflamed. Now, what will happen is when you recall the patient and remove this and the papilla is inflamed, you will have a hard time cementing the final restoration. So make sure that the papilla is breathable, and for that, you want to ensure that the interdental or the gingival embrasure is being completely cleaned off. Okay, you do not want any material over there. Give a nice profile near the gingiva, do some finishing, polishing, final buffing. So these are basically your denture finishing, polishing tools, nothing else, no rocket science. This is from the labial view. Patient is very happy. Immediate correction. 1.5 hours में मैंने root canal भी कर दिया, tooth preparation भी किया, and I gave him temporary also. And with some photography, you can see that the crown is almost as good as the natural tooth. The 2-2 is natural and 2-1 is your temporary. Pretty decent job. Okay. So this is exactly how you want to make your indirect putty. Now this is a workflow जिसमें सब कुछ एक slide में रहेगा. So after the whole workflow is being shown, you can take a screenshot or a picture. So the first thing that you want to do is make primary impression or do scans. After that, you need a wax mockup or a digital mockup after pouring the cast. So you need a cast with the mockup. Then you need a putty index. So basically, you can use C silicone putty, which is economic. You need separating media, which is Vaseline petroleum jelly. Okay. After that, you need to load the gun and dispense it. After that, you have to position that putty index to let it set on the prepared tooth. Then you remove the putty index, check the fit and occlusion. After you check the fit and occlusion, you do the finishing polishing. And after finishing and polishing comes cementation. So this is the entire workflow of how you do the indirect temporization using putty index. Okay. I will wait for 10 seconds so that if you want, you can take a screenshot. And this is all that you need to know. So let us move ahead. Now, there are some indirect temporaries. Okay. Means what? That you did the preparation and then you remembered, oh, primary impression तो भूल गया, mockup है नहीं, cast नहीं, कुछ नहीं. So you want to immediately make a, an impression using alginate. Pour the fastest stone that you have in your practice. Once it is poured, you apply some separating media. Here I'm talking about is the soluble alginate. Okay, the pink liquid which we use for dentures. And then use any composite that you have in your practice, any clinical composites. Okay, and do the build-up on the cast, carry it to the patient's mouth. And this is just basically an indirect composite veneer, which I did for a patient in whom I had to temporize for a period of 6 months. Why? Because I had to remove the tooth in future. The tooth had internal resorption. So the patient did not want to go for ceramic veneer. It was very expensive and it was supposed to stay there for just for 5 to 6 months. So we chose to give a nice composite interim prosthesis, okay, which is designed for 3 to 6 months. And she was a dentist only.
Sir, excuse me. Sir, I want a
Yep.
question.
Yeah, please
So
go
I
ahead.
have a patient, 7 year old today. Uh,
Okay.
sir, so उसके and same like this case. Uh,
Okay.
both tooths undergoing RCT today. Then his parents don't want to use permanent restoration like PFM or zirconia because he is only 7 year old. Then I
Correct.
just thought I will give like this temporary composite restoration. What do you think, sir?
You can give temporary composite restoration like this, or you can
Yes,
also
sir.
choose to give a CAD milled PMMA crown from the lab. So basically, you just do crown preparation and ask the lab guy to make a CAD milled PMMA. So CAD milled
Sir,
PMMA can stay up to,
but it is
yeah,
economic, sir, because they are
yeah,
not
yeah.
want to. Yeah.
400-500 rupees
Cat,
the lab guy will charge, not more than 600 rupees per crown. So you can choose, say, how much ever, 2 3 thousand. Now for a composite also, I charge 4 to 5 thousand.
yes,
For
yes.
Emacs, I charge 15 to 20 thousand.
So, what do you
So
think? EMX is good for 7 year old girl or
no, no,
big
no,
girl
no,
also?
absolutely not. Absolutely, none of the ceramic restorations are supposed to be given before the skeletal growth is complete. So for a woman who is 7 year old, you need to wait for at least 7 to 8 more years till she turns 15 or 16. And only when her skeletal growth is complete, you can give permanent restoration.
Yes, sir, what the name? PMM, Cat can PMM, PCM.
PMMA is basically polymethyl methacrylate.
Okay, sir.
Okay, the
Thank you,
same
sir.
same material as the denture. जैसे डेंचर होता है ना,
Okay.
कोल्ड क्योर होता है, हीट
Yes,
क्योर
yes.
होता है, दैट इज
So this
बेसिकली
is good for that, na?
PMMA.
कि
Yeah, yeah,
हाँ
it's
वो
good.
जो बच good.
You can give PMMA. Yeah.
Okay.
Or you can do what I did. However, whatever suits you. Both are fine.
But permanent restoration is not a good solution, like PFM
No,
or
no,
zirconia, like
no,
EMAX
no,
is
no.
also not.
Not now, not
Yes,
now.
yes.
Right? All right.
Thank you, sir.
Most welcome. So this is how the patient looks. All right. So
Excuse me,
there's
sir.
the situation. Yeah, please tell
Excuse
me.
me. Sir, is PMMA the same as what typically acrylic rounds previously we used to do,
Yeah,
no?
yeah, same thing. These are CAD milled. Basically, they are made using milling, like how zirconia is made. ऐसे
Yeah,
ही
milling.
पीएमएमए के या ब्लॉक्स आते हैं और
Acha.
वो ब्लॉक्स को मिल करके लैब वाले दे देते हैं. इट्स अ वेरी गुड. आई डू पीएमएमए फॉर ऑल माय इम्प्लांट केसेस. माय
नहीं,
इम्प्लांट
आजकल
टेम्पोराइजेशन.
acrylic के बदले ये कर रहे हैं क्या?
या
PMMA. अच्छा, ठीक है.
एब्सोल्युटली.
Okay, okay, sir. Thank you, thank you.
Now, this is a case जिसमें you can see two crowns. Now, this was a Richmond crown, basically. I don't know, someone had given it to this patient in 2005. It was odd to look at it. So basically, a Richmond crown is something which has a post within. Okay.
Sir, how to
So
bond, sir, indirect composite crown?
this,
Yes, sir.
I just took some composite, I layered it on the cast. I sculpted it with my basic plastic filling instruments. फिर थोड़ा बल्की बना था बट मैंने ट्रिमिंग फिनिशिंग पॉलिशिंग कर दिया. सो आई बेसिकली मैच्ड द एज द कॉन्टूर एवरीथिंग. एंड आफ्टर पुटिंग इन द पेशेंट्स माउथ अगेन फिर मुझे थोड़ा बल्की लगा तो मैंने फिर उसको फिनिशिंग एरोटर बर्स से उसको रिड्यूस कर दिया. Basically, you can just popify a lot of composite and then trim it. But if you think you're good with sculpting, additive procedure, if you think you're good with additive procedure, nicely add it with your plastic filling instruments and cure it. If you feel that you're not good with adding, but you're good with trimming, you just add, make it a little bulky, and then trim it. Do however you want. It's basically a free game. No one is looking at you when you're doing it. You just ask the patient to wait outside for a couple of hours, or ask the patient to come back in 2 hours, and then you've done it already.
Hello, sir. So
Yeah,
once we have
please.
made this composite thing, then how we are going to lute it to the tooth?
With flowable composite. Now it depends if you
Then we
want
have
to
to do the
remove it.
etching. We have to do the
Nah,
etching. Then we
exactly.
do the composite.
No, no, no. Very good question. Say if I did not want this crown to come out because I was supposed to remove the tooth after a while.
Hmm.
Okay. So I did not want it to come out. So I did etching, bonding, and like how we do composites. Okay.
Yes, sir.
But if I want it to come out one piece intact with the preparation as it is, then I will not do complete etching. I'll just do spot etching. Basically, just एक spot पे etch करूंगा. उसी एक ही spot पे मैं bonding agent लगाऊंगा and then I'll use flowable so that when I remove with probe, it just pops out.
Okay, sir. Okay, sir.
Right?
Thank you. Yes, sir.
So this case is a very interesting case because the tooth one it fractured. So basically, I had to remove one because there was a post space, I mean, a post along with the crown. So the crown itself had a metal post. So we removed one and we saw 1-2 was salvageable. So we prepared 1-2 and 2-1 on the other side. In 1-2, I did some composite buildup. And on the same day, we gave a 3-unit bridge. So what we did, जिस दिन पेशेंट आया उसी दिन हमने प्राइमरी इंप्रेशन बना लिया and I made a cast. So I had a cast with all the teeth. Now, with the putty index of that, I prepared the teeth and I made a 3-unit bridge made of ProTemp 4. Okay. And this is the beauty after 2 weeks when I just 2 weeks. Okay. I did not even wait for 6 weeks. It's just after 2 weeks. You see beautiful emergence profile in the region of 1-1. And if you see the 1-2 and 2-1 are also doing fine. So we gave a 3-unit Emax restoration. This was done in 2015. It's been 11 years. This is intact in the patient's mouth. Okay. So now coming to no prep temporaries. Now say the patient comes to you with additive needs. Say the patient is like, I have space between the teeth, I have diastema, close it. Say the patient says, I have smaller teeth, make them big. The patient says, my teeth are too much behind, मुझे थोड़ा आगे लेके आना है. So this is the case where you can play something else and show the patient without even doing any harm to the teeth. So what you do is you make a primary impression and ask the lab guy to give you a mock-up. Now, उसको क्या बोलना है mock-up के लिए? Say the patient says that I just want diastema closure. Ask the lab guy to close the diastema for you. If the patient says, no, I want them slightly front, you ask the lab guy to add 1 mm layer of wax. Just randomly usko bolo 1 mm add kar do. Okay. Now you just recall the patient, make a putty index of the cast and put it in the patient's mouth and remove it. You will see a layer of Protem 4 doing all the aesthetic corrections. And now you ask the patient कि मैंने diastema close कर दिया है. I have increased the bulk. How do you feel? The patient like, yeah, it's good, but now I feel it's too bulky. So what you do is you debulk the Protemp, put it back. And the patient like, yeah, now this is fine. I feel the bulk is fine. You remove the Protemp, check the thickness. Say the thickness of Protemp is 0.5 millimeter. Means the patient wants 0.5 mm of increase in the labial bulk. This is established. Diastema closure is no big deal. वो तो वैसे भी crowns या veneers आएंगे तो पता चल जाएगा. What we want to know is how much thickness of the labial aspect of process should be there. Now, I want all of you to listen to this very carefully. If you have any doubts, only after this we will discuss, because otherwise the continuity will be lost. So I'm talking about something called as aesthetic pre-evaluative temporary, APT. Okay. Now the patient is like, I want some bulk, and हमने decide किया कि 0.5 mm thickness is what the patient intends, more than the existing teeth. Now we all know that Emax restorations are good with the thickness of 1 mm. Okay. Now mock-up is done. You make no prep temporaries which are 0.5 mm, which are approved by the patient. So how much do you think we need the preparation on the tooth? We just need 0.5 mm of tooth reduction, because 0.5 हमें add करना है. So if the thickness of the Emax is 1 mm, we just have to reduce 0.5 mm. We are saving 500 microns or 0.5 mm of that tooth structure in that patient. Because simply there is no point of giving 1.5 mm thickness of Emax when 1 mm thickness can do. So now this is all about saving or conserving the tooth structure. The first law of any tooth preparation, conservation of tooth structure. So with this, so what you do is with the temporaries only you start reducing with the depth cutting burr, which is shown in the image. Make sure that you have 1 mm of reduction. So इसमें क्या होगा? Once the temporary, if the reduction is done through the temporary, you will end up only preparing 0.5 mm of the tooth structure. Do you see this? This is the preparation. Do you see the margin? This is less than 0.5 mm. Because my lab guy is like, I can make a 0.8 mm thick Emax and it will stay strong. So I've done less than 0.5 mm preparation. I do not have to reduce it further more. And this is basically an incisal overlap design. I did gingival retraction. I gave temporaries. And of course, after that, I gave permanent teeth. I don't have the picture here, but this is how we use the aesthetic pre-evaluative temporaries. They help us in assessing how much preparation is to be done, basically preserving the tooth structure. Okay. And you see a good temporary, which is nicely polished, looks really so beautiful, that you have to ensure that you've taken full payment from the patient for the Emax, because there are all the chances the patient might not turn up. And you've already given the order to the lab, so you do not want to lose your money. Okay. So yeah, ensure that the patient comes back for permanent, because otherwise what will happen? He or she will be in some party वहां पे खा रहा होगा and suddenly the temporary will come out. I'm like, sir, ये क्या दांत दिया है, टूट गया है. They're like, you didn't come for the permanent ones. I'm like, नहीं, temporary इतना अच्छा था. I did not feel the need of getting permanent. So second thing what you can do is थोड़ा कम पॉलिश करो ताकि 2-3 दिन में आपका टेम्पररी कलर आ जाए. So one thing that you need to tell your patient is to avoid any food which is having colors, especially haldi, for one day, 24 hours. Up to 24 hours, pro-temp is a bit porous, then it hardens. So first 24 hours, it is going to absorb any colored food that the patient takes. But if you've done very nice finishing polishing, the discoloration won't happen. Okay, coming to
Which
the provisional.
gingival retraction cord has to be
I use
bought, sir?
000. I use
Triple
000
zero.
knitted, uh, and it is pre-impregnated. It is already impregnated in an astringent solution.
Okay,
You can
okay.
buy the one which I use is by Sure Endo.
Okay, okay, sir.
But there are many companies available. You can use 000 if it's a very thick gingiva, very thick and deep gingiva. You can even use 00.
Okay,
But
okay,
only
sir.
these two you need.
Okay, okay. Thank you, sir.
Excuse me, sir.
Coming, yeah, please tell me.
Sir, do you always prepare indirect veneer with the temporaries on?
Uh, for any of my veneer cases, no, not every case. Only where the additive procedure is required. If the patient has already come with procline teeth and
All
you
right.
want the teeth to go back, you can't do it because then only after
Yeah.
preparing you can show it to the patient. Only while the patient has additive requirements.
And what about when patient having a little crowding, then only we can prepare directly?
Crowding we can't prepare because in crowding there'll be some part of the tooth which will be ahead of the an imaginary line. So
Yeah.
in case of crowding also it's always but what you can do is you can do all the changes on a cast. See, when a patient comes to you with crowding, the first treatment option we want to give them is of orthodontic treatment. Okay, because
Yeah,
that's
sir.
the
Then
most
patient will
appropriate.
agree.
Yeah, but
Yeah, yeah.
when you tell them the duration, the patient runs away. So you always give them the option of prosthetic correction. And when they hear कि okay 10 दिन 15 दिन में काम खत्म हो जाएगा, they are happy. And only to
Okay.
realize that this involved a lot of tooth destruction. So what I do is I show them uh, the mock-up, and I tell them that see, this is your rotated tooth. This is how it appears, and this is how it is. So I'll have two casts. One is a pre-op, one is after mock-up. So I'll show them that ये
Okay.
दांत को इतना घिस दिया मैंने कि जाके ये ऐसा बना है. So the patient needs to be priorly informed that the teeth are going to undergo considerable amount of reduction.
Okay.
Right.
All
So
right, sir.
and then once you've done the preparation, give temporary and you will be able to assess whether the preparation has been done enough or not. If your temporary comes out and you see that in some area it is very thin, means the amount of preparation has been done less. So
Less.
means
And sir,
so what I do is
hmm,
I make the temporaries before making impression.
okay,
पहले
okay.
tooth preparation कर लूंगा, then immediately I'll make temporaries. So these temporaries will guide me whether I've done enough preparation or not.
Okay. And sir, how do you give temporaries when patient is going home? Will you lute it? How to remove veneer temporaries?
So I'm coming there already.
Okay. Okay, sir.
Yeah.
So
So
what is no
Thank you,
prep
sir.
veneer, sir? Is there
sorry.
any no prep veneer? I've read
Yeah,
somewhere.
yeah. This is basically the same thing. The a no prep temporaries, or
Okay, okay.
say the patient needs labial fullness almost as good as 0.8 or 1 means basically you don't need any preparation, but you just can't leave teeth like this without any preparation. आपको थोड़ा सा margin, थोड़ा सा flattening थोड़ा देना पड़ेगा so that the lab guy has some freedom. some preparation is always advisable than no preparation.
So
It's
that is
golden rule.
additive and no वो भी तो वही है ना additive prep भी
Yeah,
तो
additive hai, but say with just nearly
minimal.
point 0.2,
Oh,
point 2,
okay.
0.3 mm of preparation, the lab guy will be able to give good shape of the final process. Otherwise, what will happen? The process might just turn up really rounded or bulky.
Okay, okay, sir.
No.
And so one more question.
Yeah.
In the last slide, you showed that in this one only, you prepared the incisal edge with its natural anatomy, not in butt joint. Why so?
Sorry, come again?
Incisal edges preparation, sir, आपने जो prepared थे, yeah, you go with
Um,
the natural anatomy, not in the
yeah.
butt joint.
Never,
Why
because
so,
you do
sir?
not want to leave any unsupported tooth structure which can later on fracture. Where your all
Okay,
your preparations should be rounded.
okay, sir. Was the incisal edge overlapping veneer design?
This is an overlapping design. I showed you in the previous slide. No? See this. This is overlap, incisal
Uh,
overlapping.
okay, so
This
your
is incisal
veneer
overlap.
is going. Okay, okay,
Yeah, it will
all
be a
right.
J-shaped veneer. If you see it in the cross section, it is going to go from the labial and slightly on the palatal aspect. So
Okay,
the
sir,
key
will it
to
not be fractured
no, no, no. So
with the
basically you ensure that the lower teeth don't hit the junction. It can hit the
don't
veneer
hit the
or it can hit the natural tooth. It should just not hit the junction. So the this is how you decide where you want to place the margin on the palatal aspect, that the margin should not, like the lower anterior shouldn't come and hit the margin directly. Either it should be on the veneer
all
or the tooth. Both is okay. But that's a again huge
right.
topic.
Thank you,
That's
sir.
like we started talking about veneers. All right, so I think we'll come back to provisional luting agents, and I just have a few slides. After that, we can have a detailed question answer if time permits. So the purpose is to secure the temporary processes while preventing micro leakage. You want a balance between retention and easy removal. You do not want key Niklena, and you do not want that it just pops out. And then you want to ensure biocompatibility and simple cleanup. Cleanup is very important. Okay. So these are the types of provisional luting cements. Well, I use only two. I use non-eugenol. Okay. Like Temp Bond or Relax Temp, anything, any of these I use. And sometimes if I know that it's a veneer, if it's just two veneers, and these non-eugenol will not solve the purpose of retention, then I use resin based. But I don't use resin based cements. I just use flowable composite with spot etching. I think we already discussed. थोड़ा सा spot etch करके थोड़ा सा bonding agent लगा के use flowable, and it is going to stay. When you remove it, it is easily going to come out. Okay. So methods of removal: you use an explorer. Worst case, you use a crown remover. And if you feel that it is stuck, it's not coming out, then you use a burr. But while you use a burr, there is a chance that you might alter the anatomy, which might again, cause misfit of the permanent prosthesis. But you do the first two things. And then there are some other ways to temporize, which is 3D printed resin, which is not very strong. Then someone asked me about CAD milled PMMA. This is a very, very effective solution. Say आपको मॉकअप ये सब नहीं किया and the patient is okay कि हाँ चलेगा, कल तक temporary मिलेगा तो चलेगा. So any lab guy who is a nearby local lab guy will be able to give you a CAD milled PMMA in a day's time, because it hardly takes half an hour for him to mill it. Designing takes 10 minutes, milling takes 40 minutes. So when the milling cycle is available in the entire day, he can finish it on the same day. So you can always ask the lab guy to give it to you on the next day. You can use heat cure also, provided the lab doesn't have a milling machine. Then you can just ask him कि आप heat cure के दांत बना दो, like just like how you make dentures. Or There is one thing which I have seen during post graduation. We used to see that few people used to use cold cure in the patient's mouth. Never, never ever do that. Tooth molding acrylic आता है, which is cold cure. I think blue and red bottles. So the red one is cold cure, blue one is heat cure. So this is meant only if you want to make indirect temporary on the cast, but you never use polymer monomer in the patient's mouth. Okay. This is it about temporization. So yes, a well-crafted provisional is not a temporary solution. It's a blueprint for lasting success. So always, in my humble opinion, temporize. Always, always temporize. Be it a RC treated tooth, non-RC treated tooth, anterior case, posterior case, anything. I temporize almost all my implant patients and all my full mouth implant patients, all of them. I use multi-unit abutments and I used CAD milled PMMA to temporize. So the only reason why you do not want to temporize is you do not want to temporize it. There is no excuse. You can follow me on Instagram. I run this channel called Prostho Tips, and I off lately I'm not very regular, but I keep posting some or the other Prostho Tips on my Instagram. Thank you very much. Now, if you have any questions, you can ask me.
Sir,
Yeah, please.
sir, do your patient come for the final prosthesis when you send them with the temporaries?
Yeah, I have planted a chip in my patient's mouth. If they don't come back in 10 days, I just press the button and the temporary explodes.
Actually,
Okay, I'm
sir,
just
one of
kidding.
my
What I
patients.
do is see, I charge full. Even if I given them
Okay,
temporaries, I charge at least 80%. अगर known है तो 70%, उससे कम नहीं. If the patient is say अभी
okay,
मैं मेरी school teacher का कर रहा हूँ and she has been my patient for
yeah.
past 10 years. So from her, of course, I won't charge 100%, but still I charge her 70%. I have done full mouth preparation. I am giving zirconia. But मैंने temporary दिया है. The temporaries are so beautiful that she's like, I'm able to eat and everything, anything. मैंने
Yeah,
बोला
sir,
अच्छा
that
है,
was the
but
my question.
yeah. So
One
one
of my
thing what you
patient is with temporary on since the 3 months. वो वापिस ही नहीं आ
uh,
रहे, 3 महीने से टेम्पररी पे
हाँ,
है.
ऐसा ऐसा रहेगा साल में. हमारा आज भी एक ऐसा पेशेंट, एक से दो पेशेंट रहता है जो टेम्पररी के साथ
Hmm.
चला जाता है because they did not have the budget for permanent ones. But that's okay. If the temporary is doing good for them, I think that's what God's plan is. So let's not disturb that. It's okay. एक पेशेंट से हमारा कुछ बिगड़ेगा नहीं. When you are doing good for other 99, let the one have fun.
Okay, sir.
You can always choose to keep it slightly unpolished or just don't polish it. And the patient will definitely turn back to you in 3 days with haldi stains on the teeth.
All right, sir, I will do that again.
Sure, sure.
Sir, you gave CAD milled PMM in every patient
Yes.
the very next day or the same day?
CAD milled PMMA on the next day.
Next day. You just told that it takes 2 to 3 hours for tooth migration. Then
Yeah.
why on the same? Then why you don't give on the same day, sir?
This is only when it comes to a case like that lady told about that 7-year-old or 8-year-old kid who wants a semi-permanent solution. Basically, not a ceramic restoration, but something which goes on for up to 7 to 8 years. So in that case, I want to give CAD milled PMMA because they are more color stable and better in terms of the elastic the elastic modulus of CAD milled PMMA is better than ProTemp. So in that case, I would do. Otherwise, I do all my cases with ProTemp. I don't go for PMMA. I do
Okay,
PMMA only in implant cases.
okay.
So
Right?
what
But
is
it,
How do you
immediate dentine sealing, sir? Immediate dentine sealing. Yeah, ideas.
uh, yeah, that is basically when you've done the preparation and in a vital tooth, you do not want the permanent, and you do not want the patient to experience sensitivity after the luting of permanent restoration. So in that case, you apply bonding agent on the tooth, you cure it, and depending on what bonding agent you have, say if it's an advanced 7th generation bonding agent or 8th generation, you just need one layer of bonding agent. But if it's anything below, you need bonding agent and just a very thin layer of flowable composite around in the exposed dentine. It's only for exposed dentine. If your preparation is in enamel, you don't need to do IDS because it is immediate dentine sealing. Wherever dentin is
What
exposed,
is
you
the
just
gluma then, sir? Gluma than gluma.
gluma
Oh,
is basically a replacement. It works in some patients. It may not work, but it is relatively newer when it comes to sealing of dentin. So I don't have any personal experience with gluma,
okay, okay, sir.
but IDS has been working great for me.
Using of bonding agent and curing it, huh?
Yeah, yeah, yeah.
And then placing the I mean permanent.
Yeah. So you do IDS on the day of preparation. You don't do it on the day of
Oh, vital cutting,
cementation.
huh? Vital
Yeah,
cutting
yeah.
case.
Vital
Acha.
tooth preparation.
Preparation, sorry,
Uske
sir.
baad,
Yeah, vital.
yeah, yeah. After
Yeah.
that, immediately you do dentin sealing, and you will see miraculous result. The patient is barely going to experience any sensitivity.
so
Bonding
then you
agent,
take the
curing, and then
and
again flowable composite.
Uh, yeah. If the bonding agent is anything below eighth generation or
Okay,
advanced
okay,
seventh
okay.
generation.
Okay,
Dr.
okay.
Akash, can I answer the
Yeah,
question of
yeah,
Dr. Priyanka?
yeah. Please, please.
Yes,
She's Dr. Rimi.
yes. Dr.
Okay.
She.
Priyanka, Luma is nothing but it's a fifth generation bond. So the
Okay,
chemical
okay.
composition of that is nothing but it's a fifth generation bond. It's just that the thickness, the layer thickness, they claim to be lesser. You're supposed to
Oh,
take it like all other bonding agents, supposed to scrub it on top of it for the IDS results. So they
oh.
claim it, but technically it is bonding agent only, chemically.
So
Thank you,
basically,
ma'am.
yeah, basically, the most ideal bonding agent for your immediate sealing is fourth generation.